Thank you everyone for joining us today for the Value of Information Technology in Rural Healthcare webinar. Allow us to take a moment to introduce Aspire Technology Partners. Aspire is headquarters in Eatontown, New Jersey. We have local operations in Mount Laurel, New Jersey, as well as White Plains and Albany in the state of New York. We work with our customers for their business transformation by leveraging the power of digital to achieve their defined outcomes. We act as an extension of their IT teams through our managed services and provide innovative and actionable industry perspectives for our client partners. Aspire's core strength is anchored on our dedicated team of experts delivering advanced technology solutions and services that revolve around our core practice areas, including enterprise networking, collaboration, cybersecurity, data center, and cloud, mobility, IoT, and managed services. Today, we're going to be having 3 speakers join us for this webinar, and I just want to take the time to hand it over to each of them to introduce themselves to you.
Good morning. Thank you, Kathleen. My name is Elizabeth Weir, and I run a small rural community hospital in the southern tier of New York State.
Good morning, everyone. Thank you. My name is Ray Babwitz, Director of Communications, Government Relations, and Marketing for Community Health Center of the North Country. We operate 4 federally qualified health centers across the rural part of northern New York State. I'm glad to be here today.
Good morning, everyone. My name is Sandeep Krishnan with MedTec Interlinx, and MedTec Interlinx works with a lot of rural hospitals and community health centers as a consultant, helping them develop innovative solutions for improving healthcare access in the rural communities. So with that said, Katie, I'll take over and start. We'll talk a little bit about the agenda for today's webinar. This is a second in a series of webinars we've had. In today's webinar, we'll talk about how a rural community health center in the North Country that Ray is representing, and a rural hospital in the southern tier of New York State that Beth is representing are continuously improving access to quality healthcare services through innovative programs for their rural communities. They will show us how broadband and clinical technologies can be leveraged effectively to build partnerships with urban medical centers and specialists to deliver timely and effective clinical outcomes for patients in these rural communities. So we'll start off with a YouTube clip showcasing some of the work that the Community Health Center of the North Country has done. And then following that, Ray Babowicz will start his presentation. So Katie, we can start the YouTube clip.
Community Health Center of the North Country operates 4 federally qualified health centers across the North Country here in New York State. One of the bright spots that has come out of the pandemic, which I know on the surface sounds kind of odd, is the use of telemedicine. Here in rural America, where there's transportation challenges that most people wouldn't be able to comprehend in urban America, it's a game changer. I think one of the places where we've seen the biggest change with the use of telemed is probably in our behavioral health and substance use care coordination service lines. There's still, I think, a stigma attached to someone coming into the facility for a behavioral health appointment or a substance use care coordination appointment, and it stops a lot of people from reaching out for care. With the advent and use of the telehealth platform for those visits, we saw a huge ramp up, not only in quantity, but maybe even more importantly, a dramatic drop in no-shows. For people with intellectual and developmental disabilities living in our houses or just receiving other services we provide for that community, obviously there is a whole unique set of challenges for them and their caregivers when it's time to come to any type of medical appointment. If they can get those checkups, get those check-ins, get some of that preventive work done on a virtual platform like we are doing now with telemed, It's a great way to keep people as safe as possible, but not avoid the care that you need to stay healthy in other ways.
On the WebEx platform, we are able to connect with people in the outdoor recreation program, provide people personal training, and connect with students in the elementary schools throughout the North Country. To be able to see that people are learning new skills on these online platforms has been very rewarding.
There is a huge shortage of dentists. In St. Lawrence County alone, there's one dentist for about every 3,000 residents.
We have been able to render in the neighborhood of 1,000 teledental visits in the last 12 months, visits that otherwise wouldn't have taken place thanks to the telemedicine, teledental equipment and capabilities that we have. The thing that's been most exciting recently is along the lines of that diagnostic work, we're performing limited evaluations for people who are having an acute problem, whether that be swelling, pain, something broken, whether that be a tooth or a filling. My team and I are able to diagnose and offer treatment modalities to the patient to get them out of pain and help them to feel confident that there's a way out of this dental emergency that they're experiencing.
It's all about providing equitable access to care, to be at an organization that helps build healthier communities, not through just access to healthcare services, but in other ways. It does make you very proud. Working with Aspire has been critical for us in ramping up our telehealth, telemed platform. We don't have the internal resources to do that all on our own. So to be able to have the expertise of a team at Aspire made a world of difference.
I'll now hand it over to Ray to kick it off.
Thank you very much. Appreciate it. I think I always like to start by going under the assumption people don't know what federally qualified health center is, which, as you can see, is a community-based organization providing comprehensive primary care, preventive care, including health, mental health, substance use services, and many other things.
So welcome everybody. My name
which we have health centers. I think the integration is the model that really built. Very proud of. I think, you know, a lot of times some of the people that health centers don't understand the size and scope of who we are and how many people we serve now. You know, here in New York State, there's millions of people that get their care at a health center now, and across America, it's about 30 million people now, including some of the figures you see in there. 1 in 3 people living in poverty, 1 in 5 Medicaid beneficiaries. The point I like to make is that our doors are open to everybody. You know, by mission, we're here to be the safety net, but anybody can utilize their services, whether you make $1 a year or $1 million a year. And, you know, it all sounds great on paper, but you can see in regards to the Healthy People 2020 goals, and just looking at Medicaid patients, saving 24% per patient is a lot of money. Sure, we have to make sure those savings are reinvested properly so we can further enhance and strengthen the healthcare environment. But just having the savings on the front end is an important piece. So it's not to downplay the importance of other providers of healthcare in the continuum of care. But I think FQHC serve a very unique position in regards to how we provide healthcare, especially in rural communities.
Ray, if I may ask a question here, given the rurality and the low population density in the 7-county region, that North Country region that the Community Health Center of the North Country serves, could you tell us a little bit about the development of broadband infrastructure in the region and how the Community Health Center has leveraged that for your IT development?
Sure, it's a great, you know, we can't obviously provide the services, you know, without that broadband network. I think 2 ways to look at this. I'll break it into real quickly, obviously, hard assets that are out there. The North Country Telemedicine project has really done a great job in development and deployment of a broadband network in our rural communities. And a lot of this obviously is funded, through government, specifically the federal government. And by this, if we look at it from an anatomical perspective, they're laying the spine, they're laying the foundation. They're not providing the internet service like, say, a Spectrum or a West Telecom is. An organization here locally known as the Development Authority of the North Country, or DANC, has really laid out the spine, the foundation that internet service providers are utilizing. But besides that, there's a lot of soft assets too, Sandeep. There's a lot of, let's call them telemedicine coalitions here across the North Country, where providers and stakeholders of all types get together to make sure there's a better understanding of how telemedicine, how telehealth can impact healthcare in the communities we serve. And that includes, digital inclusion groups to make sure people have that access, can afford it, and understand how to use it, once it's laid out there. And finally, our team has done a great job, I think, going out there and finding sources of funding, and luckily being awarded, money through some things like the FCC grants that have come out over the past couple of years and continue to.
Thank you. That is really gratifying to know that.
As far as, an implementation timeline, this is, like I think I said in the video, it's funny, we realized the importance of telehealth, before the pandemic came along. And fortunately, I think internally, we had at least laid a little bit of groundwork, as you see in the fourth quarter of 2019, in regards to building a more robust platform here for our health centers. Our first priority, hands down, was our set of people we serve with intellectual and developmental disabilities, and just as importantly, the teams that provide care to them. It's great to be able to have that preventive care visit with our health center and with the person living in that house without having to bring them into the health center. And that's not just from a pandemic standpoint, again, just the transportation challenge that exists. And that's why that was priority one, before moving into more primary care and behavioral health and substance use services in the first quarter of Q1. I think, honestly, primary care got pushed up more quickly because of the pandemic coming on and us needing to minimize people coming into the health center as much as possible. And then, of course, oral health care. In the third quarter of 2020 is when we first started to roll that out, when we were allowed to open up our dental suites again by the Department of Health. And although not, the fix to the foundational challenges we have in workforce, it really has helped us alleviate, some of the pressure on the system and get more people through for their preventive visits. Next slide. Here is kind of a synopsis of figures on the right-hand side. As you can see, we really have started to develop quite a robust number of visits on a quarterly basis. And although that's fourth quarter, it didn't vary much throughout 2021. If you looked at all our figures, it generally fell somewhere between 900 and 1,000 visits per quarter. And not surprisingly, from a standpoint of what services they were accessing, it pretty much worked out the same as well. And I think you can see that's where it really helped us out in the behavioral health, mental health world, as well as the primary care and oral healthcare world. Again, just the fact that it reduces some of what have become known as the social determinants of health, whether it be that transportation, I think being the biggest one, or even if you have transportation, those long distances that you have to travel, or maybe the lack of adequate transportation, it's really helped with that. But I think the most important thing on this slide, honestly, is really helping out with that perennial shortage of clinicians. Look, unless a miracle comes along or the perfect world develops, we're never going to completely overcome that shortage. And I really think that's where the telehealth platform can help all of us but especially in these rural communities.
So Ray, we talk about, technology and all the broadband, but eventually it comes down to the people. And you hit two demographics. It's the providers and the patients to whom, who use this technology and who on a day-to-day basis. What has, over the period of your program development, what has been the perception to technology and specifically to telehealth among your providers and patients? And has that perception, have you seen that change in perception during the ramp up of these services during the COVID pandemic?
Yeah, it's an interesting, we could spend hours probably just on that alone. It's, as with anything that is relatively new in our lives, people react slowly to change. Initially there was hesitation amongst the provider population, I think, to a larger degree than honestly the general public as far as accessing. And an interesting note on the general public, though, one would have thought immediately we would have seen huge jumps in younger demographics coming in. And it actually was initially the reverse. We seemed like we were seeing older populations gravitate to the telehealth platform quicker than the younger population. Why that is, I don't know, but it was an interesting thing we noticed. Now, I think since then it's pretty much, evened out across the board probably. I don't have any figures in front of me, but that would be my guess. And again, as people started to realize, whether it be the provider population or the general public population, that telehealth was going to be an enhancement, it was going to be a complement to the services we already provided, everybody kind of became more comfortable with it as we got deeper into the pandemic and then coming back out of it in 2021. Even from a marketing perspective now, we don't really market it other than it's another service line we provide to make it as convenient, or to make our care as convenient and as accessible as possible for both the patient and the provider. And when they both agree that is the best modality at a given time, it's a great tool to use.
Thank you, Ray. I think those are all very valuable perceptions, and I think that will, and I hope that continues to add value to your patients and providers.
Yeah, the other thing I would throw in there quick as we look at the sustainability and optimization is we have to make sure, people in general understand that no one's going to be forced into using a telehealth platform. Everybody has to be comfortable with it. And if you're more comfortable and clinically it's better for you to come in for a face-to-face visit, that's still what you're going to get. And we will figure out a way to get you here if there's a problem. This all sounds great, and we know it's a wonderful tool, but we do need to make sure some things are overcome to make sure it's sustainable. Telehealth reimbursement parity is paramount. It has to be there. You can only operate something for so long at a loss, or obviously no one's going to be receiving the care. So we need that reimbursement parity to be there, which really just means we should be reimbursed and need to be reimbursed the same as we would be in many cases for a face-to-face visit. And a lot of that's going to take continued regulatory reform. We've come a long way. There's a lot of support from every level of government, from the White House down to local city councils, but you can't take any of that for granted. We have to continue making clinicians comfortable with that virtual visit. Obviously younger providers are quicker to gravitate and wrap their arms around it than providers that have been providing care for 30, 40 years. Equitable access to broadband, which we talked about on the front end. That backbone needs to be in place. But once that backbone's in place, we need to make sure that people can afford to access it. And then once that access is there, that they have the ability to go out and purchase a device. And then once they have that device, do they know how to use it? So all these pieces need to come together for the telehealth platform to continue to flourish and expand. And again, especially in rural areas.
Well, thank you, Ray. These are all excellent observations, and we wish you and the Community Health Center of the North Country continued success in the work you're doing in bringing access to quality and affordable healthcare in the North Country, leveraging all the broadband and grant funding opportunities you have. So wishing you all the best. So now we are going to change tracks, and Ray gave us a perspective of things that happen in rural communities from a community health center perspective. Now we are going to look at some of the work that has been done by Ira Davenport Memorial Hospital in Bath, New York, how they have leveraged technology in bringing access to their hospital-based patient population. And to give us that overview, I would like to invite Elizabeth Weir, who is the site administrator for Ira Davenport Memorial Hospital. Beth?
Oh, thank you, Sandeep. And Ray, I just want to acknowledge one of the things on your last slide, which is the reimbursement parity. Yeah, we can't focus on that enough for a sustainability perspective, as you mentioned. So thanks for saying that, and I'll probably echo that later. Thanks for being here today. So a little bit about Ira Davenport Memorial Hospital. We are a small rural community hospital in the southern tier of New York State. We are licensed for 35 beds, but quite honestly, we only operationalize about 12 of those. We have a 120 bed skilled nursing facility that's attached to the hospital. We serve a community of about 97,000 members in Steuben County in rural southern tier. We are also a federally designated mental health provider and primary care provider shortage area, which feeds right into the necessitation of having a robust telemedicine department. The department sits at Ira Davenport because of its rurality, but does share leadership with Arnot Medical Services, which is the physician wing of Arnot Health. We do serve the entire system. And included, there are some of the programs that we have up and running right now. Next slide. So about 10 years ago, Arnot Health System did become a member of the Western New York Rural Broadband Healthcare Network, which afforded us the opportunity to take advantage of subsidized broadband services. And since we were a member of the pilot program, those subsidies do continue and help us fund what we're doing in a substantial way. A couple of years beyond that, we had the early beginnings of our telemedicine department, and that started with some initial grant funding from STREDIC and from the USDA to begin our remote patient monitoring program. Driving that initial program was our newly recruited telemedicine director and the development of just an emerging telemedicine department and committee. As we started the remote patient monitoring program and then added a few smaller programs, it became really clear that we needed to change the structure of that committee and devise more of a governance model. So it went more from like a project-based department to a more systematic and coordinated approach to telemedicine. That group also oversaw compliance issues like HIPAA and confidentiality with a telemedicine program, security of our devices, billing, and then really, of course, following the ever-changing CMS and insurance regulations in waivers, especially that came to light during COVID. So our program development, we did have those humble beginnings with the remote patient monitoring program. So we chose our patients based on the Steuben County Community Health Assessment, and in coordination with our local AMS office, we identified some patients that would benefit from the program and hopefully decrease office visits and those preventable emergency room visits. Just a short story about how technology can help. We had one patient who fit the bill, but in the Finger Lakes region, it's a lot of hills, it's a lot of valleys, it's a lot of lakes. And some people do not have internet access. And quite frankly, this person didn't even have telephone access. It didn't go up her road. So what we did was a very ingenious solution. We set her up with a satellite phone. And with that, she was able to call into the office her daily medical observations. So she was able to participate in the program. So even though there's those types of challenges out there, there's usually some type of technology that we can employ to help people fit in with that. We also added a teleretinal program, and that was in a partnership with not necessarily within the realms of Arnot Health, but they were independent practitioners that knew we had an emerging telemedicine program and asked for our assistance. So that program for those practices for teleretinal, we have a high proportion of diabetic patients in our community, helped with that. We also, if you've ever wanted a dermatology appointment, you know you probably have to wait 3 to 4 months for that. So we implemented a teledermatology application to use with your smartphone or a tablet. And it employed our Arnot Health dermatology physicians. So rather than waiting 3 to 4 months, you could snap a picture, download the app, send it in, and you would have a response, a diagnosis, and a treatment plan within that 24 to 72-hour window. The next larger project that we implemented revolved around behavioral health. We noticed a increase in our behavioral health patients coming through our emergency department. They fell into, different categories. There were some that were easy and the provider knew, okay, this case is pretty severe and that patient needs inpatient psychiatric care, and that was a transfer. Other patients were clear that they could be safely discharged with follow-up appointments for their behavioral health needs. But it was that group right in the middle that our provider needed some assistance with. So Vital Access provider of New York State, this was a grant-funded project, we were able to develop a program for telepsychiatry consults within the emergency department. We have a behavioral science unit within our organization that we could easily tap into. So that was a good partner for us to have there. And it just allowed our psychiatrists to have that consult with the patient in our ED and make that, help that provider make that decision of transfer or a safe disposition. So overall, that speeded up the throughput in our emergency department. And if you've ever run one of those, throughput is a key metric that you always want to improve on. And I'm happy to say that within the last week and a half, that had been relegated only to our ED as a consult mode. In the past week and a half, we've actually been able to expand that to actual specialist visits on our inpatient and our swing bed unit within the hospital. So again, a start of a program that we've been able to expand upon. Our next larger project, again, with VAP grant funding from New York State, was for teleneurology. I have a little bit more information on the next slide, but it was first launched down at our main campus at Arnot Ogden in Elmira to provide some neurological coverage on off shifts or when we did not have a neurologist on site or even on call. So that was implemented, but we knew from a community perspective that Ira Davenport really would need to go forward and seek that primary stroke care designation, and we did. Telepsychiatry and telewound we implemented over at our skilled nursing facility. The telepsychiatry really helped us with our gradual dose reduction of anxiolytics, which is a Department of Health metric that all nursing homes will follow. And telewound afforded the opportunity for our wound docs to see residents with wounds, see the wound progression via telemedicine visits, and avoid those really costly transportation cost, and also prevented a lot of discomfort for moving those patients to an in-person visit 30 or 40 miles away. So and you'll kind of notice a theme throughout here that these initiatives were built on the foundation, of having that strong broadband and infrastructure, but also that we utilized partners that were available to us. It's a vital part of the telemedicine success. So here we are with our prime. Yeah. Oh, I'm sorry. Go ahead, Sandy.
Please go ahead. I'll hold off my question.
Oh, okay. So our crown jewel in our telemedicine program really was the accomplishment of becoming a New York State Department of Health designated primary stroke center. It was over a year-long process. Again, we were fortunate to have that VAP grant funding, and we built on that strong telemedicine foundation, with the infrastructure and our partners. We involved literally every department on our campus in designing this program. Everybody from housekeeping to lab, radiology, PTOT, our rehab center over in the nursing home, and then of course our really strong nursing and medical support. We forged new community partnerships. We strengthened existing partnerships. If someone didn't know, in New York State, if you were an ambulance agency and you had delivering a patient with symptoms of a stroke, unless the emergency department had this designation, you had to be bypassed. What did that mean? That meant 45 minutes more on the road time until you got to an ED that had that designation. We knew we had to do this, and we had to do it well, and we had to be up and running to serve our community and provide this really vital service. So when it was all said and done, we were like, wow, we were really proud of this. And truly, it really was a catalyst for growth within our organization. We knew what we could accomplish. We kind of took it from there. And it most certainly, it says here, encourage new levels of teamwork. We performed a gap analysis, and we really created kind of like a war room. We had whiteboards and we had poster boards of every standard that the Joint Commission and Department of Health necessitated to have a program up and running. And it wasn't until every one of those standards had a green check mark by it, that's when we called up the Joint Commission and said, we are ready for our survey. And we got our certification. And then what the Joint Commission really does is act as an agent for the Department of Health. So then they turned over their information, and we were deemed appropriate, and we got our primary stroke center designation. We got it in December of 2019. And the first year, we had about 100 patients delivered to us via the ambulance agencies. It's grown since then. We've had the opportunity to provide some robust education to the community and kind of socialize that idea to the volunteer and the commercial concern that it's okay, that your patients will do well when they come to our emergency department. And I'll tell you that you kind of worry about the sustainability that's been mentioned before. This program was financially sustainable within the first 6 months, and we have never looked back, and it's been sustainable ever since. So we're really proud of that.
Well, Beth, that is fascinating. So with stroke care, they say time is life, and every second, every microsecond counts. And it's hard enough to do it, in person, where you have the patient and the neurologist and the stroke care team all face to face, to have the technology working. Now, you had all these components, and you were using telehealth with a remote specialist group to provide this care. How was this perceived by the Joint Commission and the New York State Department of Health while they evaluated your and accepted your application for primary stroke care center designation?
So Joint Commission and Department of Health, you know, when they write these standards and implement them, they're highly regulated and really prescriptive. But we found, you know, as we checked off all of our green check boxes, we met all of those standards. The Joint Commission actually acknowledged and embraced our use of teleneurology in service to the community. That's what it was all about. Bottom line, we're saving time is brain in a stroke. So we're saving lives and preserving function. The only advice they really had for us was they recognized that as a rural hospital, our volumes would be lower than something that would be seen in a suburban or urban area. So their advice really was, and it's something that we practiced anyways, is we kind of drilled down and looked at our annual competencies for nursing and medicine and some of the ancillary services to concentrate on those low volume but high risk procedures, such as administering the clot buster, like the TPA, just to make sure that people were up on their skills. But they really truly did acknowledge and embrace our use of telemedicine here.
Thank you.
Thanks. Next slide. And then COVID, right? It hit our shores and really kind of shuttered down our daily life. And what we found was our community and our patients were afraid to access healthcare. But we are a healthcare provider, and we had to find a way to kind of ramp that up and serve the community as best we could. So the iceberg slide here. So on the surface, you know, what do people see when they see an ad for telemedicine, whether it be a print ad or on TV or a billboard or something? They see the provider, they see the patient, and they see some type of a device in between. That's what telemedicine means to people. On the surface, really, of course, you know, you're going to add in some kind of education, you know, to make those visits happen. But it really is what's below the surface that's of concern. It needs some mindfulness and consideration. Compliance with CMS and payers as far as coding and billing. You know, was it a telephonic visit or was it a telemedicine visit? You know, you need to code those differently. Our staff had to be educated on that. Site origination, you know, the location of the patient or the location of the provider. Did they need additional credentialing, the providers, you know, based on where they were providing their service from? Reimbursement, staff support, different platforms. When you go down to the bottom, when it says, you know, enlist the support of the physician leaders and chief medical officer, we definitely had some early adopters, about 15 of them, and they were superstars. They bought right in, they understood the need for a single platform. Where we got some resistance, and hopefully this is educational if you're starting a program, providers wanted to use the platform of their choice. They wanted to use Skype or Zoom or Facebook or Jabber or one of 10 other different platforms. But we kind of had to regroup and rein them in and say, you know, you're serving Arnot Health patients. And if they choose to use telemedicine for different specialties or their primary care, they're not going to want to learn 5 different ways to access telemedicine for Arnot Health. So we kind of had to regroup and enlist the support of some additional physician leaders and our chief medical officer to say, you know what, this is a platform we're going to use so that everybody can be educated and we can ramp up quickly. And back up to the top, you know, we did onboard in our Zoom platform 158 providers encompassing 33 specialties in a matter of about 6 weeks or so. So it was really successful that we were, but again, you know, we had that foundation. All we needed to do was expand it quickly. And then, of course, you also want to be tracking and trending your volumes. As Ray alluded to before, you can't have a program just because it's a good program. It really has to be sustainable. And that's where that reimbursement parity comes in. But in that first year, we did have about 12,000 telemedicine visits. So it was really successful for us. Next slide. What the future at Ira Davenport, we are actively pursuing telecritical care, and especially driven by the pandemic, lack of specialists, bed availability, and transportation were all challenges we had to meet. So imagine having a critical care patient sitting in your emergency department, and you're not going to be able to transport them for about 24 hours or so. What we'll do is use the same platform as a teleneuro for ease of use for the staff, and we'll be utilizing the same equipment. It's just a different specialist on the other end of that call. We're also expanding primary care access. Internal customers first. We ran a banner across our internal internet site. So if somebody needed a quick access to a primary care provider, they could touch the link and get a visit that day. We wanted to kind of work out the bugs and the kinks, but we have expanded that to our external website. So again, folks in the community can kind of tap on that link and get themselves a visit that day. We have several urgent care locations around the region, and the focus really was we needed better utilization of the provider time. So say there were 3 providers in an urgent care, but only 2 of them were consistently busy throughout the day. We have recently, in the past 2 months set up a program where that 3rd provider can be in a room with that telemedicine capability, and either it can be an urgent care visit where people don't actually have to drive in, or they can expand into a primary care visit at that time.
So Beth, what we are hearing from your program is that all the different modalities of telemedicine you're doing is you're really trying to bring an integration of healthcare services in the hospital and in your emergency room through healthcare technology. Are you seeing an impact in terms of hospital readmission rates and preventable emergency department visits?
In theory, all the things that we're doing really should do that, Sandeep. Our readmission rates for our inpatient are so very low. There's not enough volume to see if that truly is making a difference. But we do have an alert system for the super utilizers, as we call them, in our emergency department. And that's one of our next steps is placing a navigator within the emergency department to kind of hook them up with those services, including telemed services. So we really would have an impact, especially on those readmissions through the emergency department. Yes.
Thank you, Beth. And in the interest of time, what we'll do right now is we'll open up the webinar for Q&A. So if there's any audience member who would like to ask any questions, feel free to do so.
And we also have, just being cognizant of time, I know we're going a little bit over, please feel free to stay on. We also have the Q&A box down at the bottom. You can insert your questions there and we'll be sure to check. If you do need to hop off, we will be sure to send a recording of the presentation to you, and we can continue going.
And if there's no questions and answer, any questions for Beth and Ray, what I would like to do is just open it up for you, a couple of questions for you both. I just wanted to get a sense of how important it was for both a community health center and a rural hospital to have the federal, state, and foundation funding to get your telehealth and your health information technology infrastructure started. Beth?
It was absolutely imperative. That was the backbone, and from the birth of our program. If we had not had that original STREDIC and USDA grant funding, I don't think we would have moved forward. It was absolutely imperative for us to have that.
Ray, any thoughts on your side?
Yeah, I would pretty much mirror exactly, what Beth said, mission critical. It had to be there for us to even go down that path of looking to implement, a service line like telehealth. You just don't, as nonprofits, we don't have the resources, in the bank, literally or figuratively, to attempt to tackle something that large.
And that's what, again, I think what we're all seeing is that there's a lot of initiatives, both from the federal, state, and local foundation level, to help healthcare organizations and embark on projects like these to get all the technology they need so that they can build programs to improve access to healthcare, especially in the rural areas, and especially more recently with COVID. Both the federal and state government, New York state government, have been putting a lot of funding. The question is for the healthcare organizations to tap into those fundings and have a very clear outline of how you want to build your programs. Unfortunately, by the time you hear about funding opportunity, you probably have 30 to 45 days to get your application and your proposal in place, and that usually does not give you enough time. So any thoughts on the preparatory work that you have to do? Forget about grants. Is it a good idea to start an assessment so that to have an idea of the gaps that you have in your programs, in your infrastructure, so that when these grants become available, you can have a plan in action?
Sandeep, I think that's really where the governance committee comes into play, so that you have that group of people and experts from all different areas of healthcare really seeing what are our opportunities that are next. And as you said, some of these grant opportunities come up and there's a minimal amount of time to prepare. And I've learned from that. But you kind of build a portfolio and have that information at the ready to kind of copy and paste into most grant applications for telemedicine. What's I think unfortunate or interesting is there are grant opportunities for telemedicine programs, and what we really need is the backup from reimbursement so that these programs are sustainable once they're off the ground.
Right.
I guess I would add, and I utilize it a lot, and I know it's kind of an oversimplification, but you need a vision, and you need a plan to make that vision a reality. And it's just as important with ramping up a telehealth platform as anything else. Equate it to building your home. You don't put in the bathroom first and then build the house around it, right? You have to have the foundation in place, for it to all come together efficiently and be able to ramp up to have a successful, sustainable, operation as quickly as possible.
Oh, thank you both. And both Beth and Ray, you exemplify your organizations who really have had a vision, understood a need, identified a need, and then went after funding programs to build these innovative and sustainable programs, both from a rural hospital perspective as well as from a community health center perspective. These are the lessons that have to be brought out so that others can, they don't have to recreate the wheel. They see your successes and they can learn from that and build on that. So once again, congratulations on the wonderful work you're doing. Wishing you continued success, and hope we have you back at these forums to hear more about your successes in the future. With that, Katie, I'll hand over the session over to you.
Thank you. Sandeep, Ray, and Elizabeth, that was great, very informative, and we appreciate all of your success stories and wish you nothing but the best in the future. If you'd like to continue the conversation, if you weren't able to join us today, please reach out to us at info@aspiretransforms.com, or you can visit our website, aspiretransforms.com, to learn more how you can succeed in your own business. But we appreciate the time today, and we hope that you have a great afternoon.
Thank you all.
Thank you.
Thank you.